Hi everyone. I know it's a couple of minutes before 6, but tonight's going to be more of a Q&A session, or if you want to know how to access some of the resources and practice questions, we can go over that too, but feel free to unmute or type in the chat if you guys have any initial questions. All right, so I know it's 6. Any questions from anybody? Can unmute or put in the chat, but like I said, tonight's just going to be a Q&A session. Yes. Let me find a picture to pull up. Give me 1 second. Okay, so let me share my screen and we'll start with the anterior compartment and then move on to the posterior. Okay, so when we think about our lower limb and the leg, we want to think about everything in terms of compartments. And so when we think of what would be our thigh area, so anything really above the knee and where our inguinal ligament is our main nerve for the anterior compartment is going to be that femoral nerve. And that femoral nerve will come from that, like the lumbar plexus, which I think you guys touched on a little bit. And then a lot of the other nerves, when we talk about the legs, is going to come from, especially from the back, is going to be more of our posterior compartment. And you're going to learn about the sacral plexus, I think, more in January when you do pelvis and perineum. But just keep that in mind when you're thinking about where these nerves are coming from. So anytime we talk about a plexus, like the lumbar plexus, we know that's going to be our anterior rami. And so what you really need to be really concerned with when it comes to your anterior compartment of the leg. So that's going to be your extensors. So it's going to be your quadriceps muscles. So remember, you have vastus lateralis, you have vastus medialis, you have vastus intermedius, and then you have rectus femoris. You also have the tensor fascia lata, and then this is all going to be that femoral nerve. Then when you think about your medial compartment of the leg, so really the inside, that's going to be things like your adductor magnus, your adductor longus, and your adductor brevis. And that's going to be your obturator nerve. So that's going to be your medial compartment. And anytime in anatomy, the one thing that's nice is when you think about these compartments, it's really one nerve that's doing all of the work. So medial compartment, our adductors, is going to be that obturator nerve. Your anterior compartment, which is going to be your knee extensors or hip flexors, is going to be your femoral nerve. And then, see, I might open up another PowerPoint. We have the posterior compartment. And when we think about the posterior compartment, we're going to have a couple more things going on here. So let me share this PowerPoint. So we kind of have this sacral gluteal area, and you're going to have gluteus maximus, which is going to be your inferior gluteal nerve. And that's one of those nerves that are coming from that sacral plexus that I've mentioned before. But again, that's just for completeness sake. You don't really have to worry about it, but you should know that inferior gluteal nerve does innervate the gluteus maximus. So that is that most like big muscle you see. Then when you come in here, you're going to see gluteus medius. And under that, it's going to be gluteus minimus. And that's going to be your superior gluteal nerve. Then you're going to have this nice triangular muscle, which is your piriformis. So that's going to be attaching from your sacrum and then going to your greater trochanter. So it's going to be a lateral rotator. And this is just going to have its own named nerve of nerve to piriformis. Right under the piriformis, you're going to have these three muscles. This top one here is going to be your superior gemellus. Then this is going to be obturator internus. And then below that's the inferior gemellus, and we call that the gemelli sandwiches. And so all of these also have their own name to nerve. So it'd be like nerve to superior gemellus, nerve to obturator internus, nerve to inferior gemellus. Then what we also really care about, well, same with quadratus femoris, so that's even below that. It's in the shape of a quadrangular space that also has its own named nerve, so it'd be nerve to quadratus femoris. Then one of the big nerves that we really care about is this really, really thick nerve called the sciatic nerve. And so some people can get sciatica. So people that maybe have their wallets that are like very thick and they sit on it all the time, that can cause sciatica. And the sciatica is really made up of like two nerves. You're going to have like the tibial nerve, and then you'll have the common fibular nerve. And so we did gluteus medius. Let me find the other. So then when we think about our posterior compartment, that's what we call those hamstring muscles or our flexors. But in order to be a hamstring, it needs two things. One is to be innervated by that tibial nerve. And then the other is that it has to attach to the ischial tuberosity, which is this area up here. And so for our hamstrings, we're going to have biceps femoris longus, semimembranosus. It's got a nice membrane to it. It's a thick muscle. And then semitendinosus, and it's got a very long tendon for what it's named as. And that semitendinosus is attaching onto that pes insulae. And so now you'll see that we do have a biceps femoris short head, but it's not innervated by the tibial nerve. So we don't call it a hamstring muscle. And secondarily, it does not attach to the ischial tuberosity. It attaches to a part on the femur called the linea aspera. So that would be that component. And so you'll see here, this is that sciatic nerve. And so really around the area of the pop fossa, and it's variable in every single body, but knowing that you're going to get the tibial nerve and then your common peroneal nerve, which is the same thing as saying that common fibular nerve. It's the same thing. Your tibial nerve, okay, there's no more pictures, but That's okay. So your tibial nerve is going to run straight through the pop fossa, and then it's going to do all of your flexors of like the leg as well and your plantar flexors. So it's going to innervate that gastrocnemius. It's going to do soleus, which is underneath that. And then it's also going to, does the sciatic nerve become tibia? Yes. So you can think of it in two ways. So the sciatic nerve will either, it's really made up of two nerves in the sense that it's the tibial nerve and the common fibular nerve that pretty much run together, but you tend to see that evident split in the pop fossa where they like really become apparent of their own nerve. So in lab, when you see the really thick nerve, like yes, it's the sciatic nerve, but it's really those two nerves combined, and you just happen to see the splitting really in the pop fossa, but it can occur much earlier. It can occur later. It's variable. So it depends. But yes, it does. And so that tibial nerve will continue to run its track. It's going to run the whole back of your leg. So yeah, posterior compartment, do all the flexors, including gastroc, soleus, all of that. And then your Tom, Dick, and very nervous Harry. So it's a part of that, which is your tibialis posterior, your flexor digitorum profundus, your flexor hallucis longus. So all of those muscles. That's the story of the tibial nerve, and then it'll go down into the foot. Then when you think of what about the common peroneal or the common fibular nerve, well, what's the story with that? And so the common, I can try and find another picture after this to show you too, but where's that picture? Your common fibular nerve is gonna kind of wrap around the fibular head, and it's gonna split into an superficial fibular nerve and a deep fibular nerve. And the superficial fibular nerve is going to innervate the lateral compartment. So it's going to do your fibularis longus and fibularis brevis. And then the deep fibular nerve is going to run in the anterior compartment, and it's going to do the tibialis anterior. It's going to do your extensor. So when we think about now the anterior part of below our knee, that's extensors. So that's going to be that tibialis anterior, which does dorsiflexion. And then your extensor hallucis longus, your extensor digitorum, your trying to think, fibularis tertius. So those muscles. Does that make sense? See if I can find another picture for you guys. So pudendal nerve is going to be a nerve you're going to cover more in when it comes to sacrum because it's going to do more innervation and sensory to some of the areas within the sacrum. So I think that's more of a January pelvis and perineum because it'll do a lot of pelvis and perineum things. So I like this image. So remember one thing with this saphenous nerve. So this is kind of a continuation slash finisher of the femoral nerve. So remember our femoral nerve is in our anterior thigh compartment. It's part of that navel. So it's that most lateral structure we see in the femoral triangle. And so our femoral like artery and everything like that, it's going to pierce that adductor magnus. And then that's when it turns into that like popliteal artery and things like that to get to the back of the leg. But what happens is with our sensory saphenous nerve, so our femoral nerve will go through and then we'll get out our saphenous nerve, and that's going to do sensation to our cutaneous slash sensation to the lateral aspect of our foot. So again, when we think about, remember, we have the tibial nerve that's going to run trek all the way in the back, and then we're going to have the common fibular nerve, which is going to wrap around the fibular head. Sorry, saphenous nerve does sensation medially, not lateral. My bad. Common peroneal nerve is going to wrap around that fibular head, and then it's going to split into the superficial fibular nerve, which is going to run in our lateral compartment. So where it runs kind of in between fibularis longus and fibularis brevis. And then you're going to have the deep fibular nerve, which is coming into that anterior compartment. And it's going to run in between like extensor hallucis longus and extensor digitorum. And you'll see it in there. So there's something in the chat. And then the only other thing is your sural nerve will do sensation to your lateral foot. Sorry, I'm really bad with Zoom. Superficial supplies the lateral lower leg. Yeah, so the superficial is going to do your lateral compartment. So kind of below your knee, you're going to have two muscles really in your lateral compartment. Let me pull it back up. And it's going to be your fibularis longus and brevis. So this is lateral. This is medial. So from lateral, you're going to have the fibularis longus, which is this muscle right here. And then right underneath it is your fibularis brevis. And those are everters of the foot. So they evert the foot, and that's done by your superficial fibular nerve. And then again, that deep fibular nerve, that's going to do your extensor compartment. So that's going to include tibialis anterior, your extensor hallucis longus, your extensor digitorum, and then your fibularis tertius. Yeah, go ahead.
If I could just ask a question. So as far as actions are concerned, specific for the anterior compartment of the low leg,
Yes.
it's really going to be dorsiflexion and inversion.
Yes. And
But when it comes to the low leg lateral, it's specifically dorsiflexion and eversion, or it's just eversion?
it's mostly eversion with a little bit of dorsiflexion, but your main dorsiflexor is tibialis anterior.
And then everything else would be inversion.
Yeah.
Or no?
Yeah, so your fibularis
Like,
longus and brevis are pretty much your only everters. I would really only consider them as everters, to be honest. And then your fibularis tertius, which is like that small muscle, that does a tad bit of eversion, and then it does more of like dorsiflexion slash extension there. And then your extensor hallucis, extensor digitorum, they just extend. And then your tibialis anterior does dorsiflexion and then a little bit of inversion there.
okay, thank you. Would you be able to go over the Tom, Dick, and Harry
Yeah,
nervous, that one, just because I feel like
yes,
we say it, but I don't
absolutely.
fully grasp it yet.
Let me pull up a picture because I feel like that's the easiest way to see it. Um, okay, I like this works. Can you still see my screen?
Yeah.
Okay, so when we think about Tom, Dick, and Very Nervous Harry, again, think about relationships. What side of the foot are we looking at to even find this? And so we're gonna be looking at the medial malleolus. So the inside, if you're looking at your own feet, you have your big toe, and then there's that big bone of the ankle. That's your medial malleolus. And so basically from anterior to posterior is really the way you're gonna go. So this being more anterior and this being more posterior. Or you can think of it being like lateral to medial. Either way works. Just like always keep it in an order. And this goes for lab too. Like I always use the tendons in this order and then I trace it back up to the muscle bellies because the muscle bellies up here, excuse me, might not be in the same order as you would like see them down here. So you really just want to use the medial malleolus as that landmark. And so Tom, Dick, and Very Nervous Harry stands for T for Tom, is your tibialis posterior. So it would be this tendon right here. Dick stands for flexor digitorum longus. So that's Dick. And then and very nervous. So we're going to have and very, so artery and vein. It's going to be, keep in mind, your posterior tibial artery and your posterior tibial vein. And then it's just the tibial nerve. So remember, tibial nerve whole time, the artery has posterior tibial to it. So Tom, Dick, and Barry, nervous tibial nerve, and then H4 flexor hallucis longus tendon. This is hairy. And so always, always when you come into lab, like look for Tom, Dick, and very nervous Harry. It'll always be in this order, and then trace up the tendon to find the muscle belly, because when you see the muscle bellies up here, they might be like alternated from what you think and can really like throw you off. So if like the muscles like tagged, follow it down to the tendon and use this order. And this is Tom, Dick, and very nervous Harry. So this is your flexors. And this includes your posterior tibialis posterior, which helps with like plantar flexion a little bit. So that's what Tom, Dick, and very nervous Harry is.
Thank you so much. Is this the tarsal tunnel as well?
Yes.
Okay.
You can also really think of this too. It's over the, so what's covering all of this is the flexor retinaculum. So in lab, when you dissect this out, it's like super thick, just like it was like in the hand, how we had the flexor retinaculum where the median nerve comes through. This is like that same idea where tibial nerve is going underneath this like flexor retinaculum here. So would foot drop occur from the deep fibular nerve? Yes, it would, because think about it. So foot drop can occur really in two locations. So we could either have injury to the deep fibular nerve, or we can have injury to the common fibular nerve. And so remember, because common will give rise to that deep fibular nerve. So if you hit it high, you're going to have the same repercussion as you would hit the deep fibular nerve. So think about it. Our deep fibular nerve is doing things like tibialis anterior, which are dorsiflexors. So if this is my foot, if I'm dorsiflexing, I'm going like this. But if I injure the nerve that dorsiflex, I can't do it. So I go like this. And so my foot drops. And so that's what you have called for foot drop there. Does that make sense, Skylar?
Yes, it does. Thank you.
Perfect. You're welcome. Go over the veins. Yes, I'll find an image. And then is veins encompassing the artery, posterior tibial vein as well? Yes, it's the posterior tibial artery and the posterior tibial vein. When nerves of the legs get damaged, yes to that as well. Let me pull this. Okay, let's start with veins of the leg. Line diagrams of blood supply might have time to get there. Okay, so when we think of veins of the legs, so the best way to do this is knowing there's a couple of like relationships as well that are important to be aware of. And so the biggest veins that we really care about when it comes to lower limb is, remember, in our anterior compartment, we have that femoral triangle. So we have a femoral vein. We also remember the femoral vein slash the artery. So when you think of veins, it's the opposite of arteries. So either way, you just like, depending on how you learn best, sometimes I like learning veins, how I learn arteries because it's easier, but just remember that veins are going back to the heart versus arteries go away from the heart. So it kind of works from like the veins kind of start from here and work their way up, but veins typically always follow arteries. So that's kind of how I base things off of. Yes, Skylar, that is navel. So femoral nerve, artery, vein, lymphatics. That's what that navel is. And so you have the femoral vein, and that's going to go through that adductor hiatus as well to come out and become the popliteal vein. And then that's one of the big relationships. And then you have this great saphenous vein. And so that's kind of running on the medial and it's formed from the dorsal venous arch. So that's arch down here of the foot, which is from the great toe or your first toe. And so it's the dorsal venous arch from the big toe and then from here. And that's going to form your great saphenous vein, which you can follow all the way up here. And then it's dumping into the femoral vein. So this is, remember your, oh, I don't know if you've learned this yet or not, but your like femoral nerve kind of, this is your inguinal ligament. And so it's kind of running underneath this, all of this, like the femoral nerve, artery, and vein, kind of how they get into the leg is kind of running under this inguinal ligament. So this is your femoral vein. And so that great saphenous vein, it's going to be formed from the dorsal venous arch, and then it's going to run up the medial side of your leg, and it's going to dump into the femoral vein. And then you're going to have, and this, remember this great saphenous vein, this is an important relationship when it comes to anatomy. So remember, it's going to run with the saphenous nerve. So if you'll remember when I showed the nerves, that cutaneous nerve that runs medially, that is the saphenous nerve, and it's going to run with the great saphenous vein. Then when you look, oh gosh, goodness. Then when you look laterally, you're going to have the small saphenous vein. So this is lateral, small saphenous, and that's going to be formed from the dorsal venous arch of the little toe, with the dorsal venous arch. So your great saphenous vein is like the dorsal venous arch with the great toe, because remember that's medial. And then your small saphenous vein is also formed from the dorsal venous arch, but really like the little toe or your pinky toe. That small saphenous vein is going to run laterally, and then it's going to dump into your femoral vein. And then it's also running into here, into your iliacs eventually. And so the small saphenous vein, it's going to run along, so the lateral malleolus, so the bump on the outside of your foot, and it's going to run with the sural nerve. And so the sural nerve does cutaneous innervation to like the posterior lateral leg. So saphenous medial, saphenous nerve medial, sural nerve lateral. And that's really like the biggest thing with the nerves there. Both great and small ultimately drain into external ilia. Yeah. So as you continue to learn this, yes, your femoral nerve is your femoral artery comes from your external iliac artery, which will connect into your common iliac artery. So you'll learn all of that come abdomen unit, but for completeness sake, knowing that your great and small saphenous veins are going to drain into your femoral vein. Or wait, that is lymph. So lymph follows blood supply. When in doubt, lymph will always follow the blood supply. Like the body is extremely lazy. And as you keep learning anatomy, like you'll see like it's not going to want to go somewhere further than it needs to be. So it's kind of all these blood supplies and like lymphatics, they like hitch a ride on each other. So that's how like all these veins, because your lymphatics are all going into your thoracic duct, which is going up to like dumping into like veins at the end of the day. So they're all going in the same area. So if you're ever lost on veins or lymphatics, if you know the blood supply, you should be able to ascertain what the venous drainage and lymphatic drainage is for that. So small goes into popliteal. Yeah, so your small saphenous vein is going to dump into your popliteal first. So you can see it there because it's kind of running like posterior, but your popliteal goes into your femoral and then your femoral into your iliacs. So it all backs one onto the other, but yes. Yes, it should become popliteal vein first. Yep. Yep, so you can track it right here. You see it going kind of into the popliteal and then going into the femoral. Yes. Is that good for venous supply? Great. Okay. Then let's do injuries. So injuries, the one thing when it comes to injuries is you always want to know. So you always want to know the best way when it comes to any injuries is like you always want to know nerves, muscles, and the action because if you know what the muscle is and you know what nerve's supplying it and you know the action of the muscle, you're able to discern what the injury is going to be. So kind of like how we talked about foot drop with the common fibular nerve or the deep fibular nerve, we know that the deep fibular nerve is going to innervate our tibialis anterior, which is our dorsiflexor. So normally tibialis anterior, this is the foot, it's going to bring it up like this. But if we damage that nerve, we can't dorsiflex, so we're gonna plantar flex, and that leads to foot drop because your foot will drag when you walk, and it'll kind of be like a stomping sound for that. And the same thing goes for trying to find a good thing for it, but the same thing goes for any muscle when you talk about it. So my advice when going through this is to break it into compartments. Yeah, so you can't like when you foot drop, it's because you can't dorsiflex. So when we talk about the foot, it's dorsiflexion and it's plantar flexion. So when we bring it up like this, when you lift your toes up, that's dorsiflexion. And when you go like this, that's plantar flexion. Like you're planting your foot into the ground, and that's how I remember it. So it's the same thing goes for any compartment. So when we think of, let's do femoral nerve, and that's our anterior compartment. So we know that's going to be our quadricep muscles. So our quadriceps, they extend the knee and they flex the hip. And so breaking up, this is the best way to go by it. Break it up into compartment. So if we damage our femoral nerve, then we can't extend our knee and we're going to have weakness and flexing our hip. And the reason it's weakness and flexion of the hip is because our major hip flexor is iliopsoas. And that is why. Then when you think of your posterior compartment with your tibial nerve, so that's going to flex the knee and extend the hip. So if we damage our tibial nerve, then we're going to have trouble with our hamstring muscle. So our biceps femoris long head, our semimembranosus, and semitendinosus. If we damage our obturator nerve, remember that does our medial compartment. So if we damage our obturator nerve, we're not going to be able to do adduction. So we won't be able to do, we're going to take out adductor longus, brevis, and magnus. And you just do that all around the compartment. So lateral compartment, if we damage the superficial fibular nerve, then we're not going to be able to evert the foot. Does that make sense for injuries?
Yes, it does. Thank you.
Okay, great. But do that for every single one. So knowing, and then the one thing when it comes to injuries is to keep in mind is, can another muscle do the action that has a different nerve? And if it does, then you have weakness. If another muscle with a different nerve doesn't have that action, then you lose that action. Okay. Blood supply, I think was the next one. Yes, let me see if I can bring up a whiteboard. Or if I have a line diagram from last year. Oh, I do. Okay. Okay, let me stop sharing for a sec. Okay. Gotcha. Okay, so blood supply. This one is to the leg and foot, but I'll backtrack to explain how we come to get this. So because this is starting from the popliteal artery, and then I'll just walk you through this because I know from just looking at it, you're like, what the heck is this? But hopefully this makes more sense. And this is kind of how I went about doing blood supplies, just kind of drawing it out and following it to the next. And it really worked for me. But doing it this way might not work for you, and you can always switch it to how it works for you. But this is starting from the leg and foot, but how we even get to the popliteal artery is from that femoral artery. So remember, we have navel. So our femoral artery comes from that external iliac that I mentioned. And so again, that's for just completeness sake. Don't get crazy about it right now because you'll learn it in a couple months. But basically, it's going to come from there. And our femoral artery is going to travel under that inguinal ligament, and it's going to come into our anterior thigh compartment as the femoral artery. And it's going to supply the anterior compartment of the leg. Then it's going to go through something called the adductor hiatus, which is in adductor magnus. And it's going to go through, and I kind of think of it as like a little swirl because it's got to get to the back of the legs. We've already done the anterior compartment. So the femoral nerve or the femoral artery is going to do like a little twirl almost. And then it's going to become the popliteal artery out of the adductor hiatus. And then we're going to see that popliteal artery and that popliteal fossa. So just how we had the cubital fossa here, the back of the knee, that area is called the popliteal fossa. And that's where we would see the popliteal artery and the popliteal vein. From there, the popliteal artery is going to split into two main branches. So let's take this one here. We're going to do the anterior tibial artery. So we're going to find this in the anterior compartment or the dorsum, which is the top of the foot. So if this is my foot, this is the dorsum, the top, versus this is the plantar. This is the one that's in contact with the ground. And so the anterior tibial artery is going to do that anterior compartment of the foot. It's going to run with what's the nerve that runs in the anterior compartment? Oh, it's the deep fibular nerve. They're going to run as buddies in there. Great. So that's kind of trekking 2 and 2. So then that anterior tibial artery, right around the area of the, what do I have? The tallow, something joint. I can't read my writing, but right around this joint, it's going to become that dorsalis pedis. And that's what you can feel. You can take a pulse there on the top of the foot. And your dorsalis pedis then is going to take a couple of turns. So it's going to give off an artery, which is going to go to the first dorsal metatarsal artery. And that supplies your great toe in the medial part of the second. The dorsalis pedis is also going to come the lateral tarsal artery. It's going to become the arcuate arteries, which will give off into second, third, fourth dorsal metatarsal arteries. And then it'll give off that deep plantar artery. So this is like everything when it comes to blood supply. So focus on the ones that are obviously like more important and more common than some of these smaller ones in the foot. So I know this is very much in depth. So just like keep it with the grain of salt when it comes to your studying and what is more important and has been talked about more. And so that is our anterior compartment and the dorsum of the foot. So tracking it back, our popliteal artery and our pop fossa is going to give off two. One that's going to go to the front, anterior tibial artery. It's running on the tibia and they're in the anterior compartment. So it's named for where it is. It supplies the anterior compartment and the dorsum of the foot, which is going to run with the deep fibular nerve. Anterior tibial artery is going to then become dorsalis pedis, which then will break into these 4 smaller ones. Then if we've done our anterior, then we need something for our posterior. So our popliteal artery is then also going to give off the posterior tibial artery, and that's where we see it the medial malleolus for Tom, Dick, and very nervous Harry. And then it's going to give off the fibular artery, and that kind of goes on the lateral leg, and the fibular artery should run with that superficial like fibular nerve from your posterior tibial artery as you get into the foot. So we're thinking plantar surface. So if this let's just go with it. This is my medial malleolus. I would find my posterior tibial artery here. And then when we get to the plantar, so under here, we're going to split into 2 again, a medial one and a lateral one. So we're going to have the medial plantar artery because it's running on the plantar surface of the foot and it's medial. Then we're going to have the lateral plantar artery on the lateral part and its plantar surface. And then that lateral plantar artery is going to be kind of funky because it's going to form the deep plantar arch, which will give off perforating branches. So think of it as supplemental branches. And then it's going to give off plantar metatarsal arteries, which turn into like the digital arteries. So think more digits as in like here. So digits like metatarsals to digits. Again, like this is super way in depth. So again, focus on what you think is more important. And then just from a side, your deep plantar arch, which comes from that lateral plantar artery. This is all get anastomosed because you have the deep plantar artery off this dorsalis pedis, and then the deep plantar artery off this lateral plantar. So they kind of form that deep, that is what your deep plantar arches form, your lateral plantar and your deep plantar. Lateral plantar from posterior tibial plus your deep plantar from dorsalis pedis equals your dorsal plantar arch. And that is really the blood supply of the leg and the foot, as well as we kind of covered the femoral artery as well. Okay, Trendelenburg sign, yes. So when you think about the Trendelenburg sign, what are we testing? Oh, good. Yeah, I'm glad it was helpful. So when we think about the Trendelenburg test, we are, yeah, so kind of gait, but we're really testing the gluteus medius, which is innervated by that superior gluteal nerve. And so when we think about the Trendelenburg test, so the way you want to do it can kind of demonstrate this to make sense as well. But say I'm testing my right gluteus medius, so my right side, what's going to happen is if this is my right side, see if I can try and identify this. If this is my right side and I want to test this side, if I'm going to stand on my right foot and I'm going to stand on my right foot and I'm going to lift up my left foot. If my pelvis on the left drops, then I have a positive Trendelenburg test, meaning I have right gluteus medius problems or right superior gluteal nerve. So if you're testing, the side you're testing is the side you're standing on. So like if I'm standing on my right with my left foot in the air, I'm testing my right gluteus medius. If my pelvis drops to the opposite, drops to the left, so it drops down on the left, then that is a positive test and I've injured my right gluteal medius nerve. Yes, the good side drops. So always think about your pelvis drops to the unaffected side. So if my pelvis drops to the left, that means I have a right gluteus medius injury. Exactly. No, that's how I always went about it. I always was like, okay, what's the side of the pelvis drop? And then the opposite side is the side that's injured. So whichever way works for you, but to kind of like how that test works, that's exactly what it is. So you're testing superior gluteal nerve, which is testing the gluteus medius. Yeah. That's a good question. I think we really do it more with the gluteus medius than we do the minimus. So I would keep it as a gluteus medius test more so, just because like medius does a little bit more than minimus. So keep it as more gluteus medius. Um, okay. I think I have a blood supply of the femur as well. Anastomosis. Let me see. And if the line diagram was helpful for the leg and foot, let me know and I can drop a screenshot in the chat for you guys if it was helpful. If it was very overwhelming, then I will not. Okay. Sure. Let me do it now because otherwise I'll definitely forget. And you can always, if you didn't get it, you can shoot me an email and I can send it to you too. Okay. So let's do this picture. Left gluteal injury is right side drop. Exactly. Yep. So either pelvis drops to the unaffected side or think about the side you're standing on. Okay. So what we're looking at here, this is our femur. This area is the acetabulum. And so what we're looking at here is we have two different anastomosis when it comes to this area. And we consider this area important, especially people that are elderly and have fractures because you can get avascular necrosis of this area as well. And so when you think about it, you have the cruciate anastomosis, which I don't, it might not, but what I'll do is I'll type it in the chat so you can see it too. But when we come to this area of the femur, there's two big anastomoses that are important. And there we go. Yeah, we're going over anastomosis here.
Nice.
Yeah. So this is important because in elderly patients, the artery of the head of the femur, it comes from this ligament of the femur and it gets degenerated in people as they're older. And so basically, elderly people are exclusively getting the ascending branch of the medial circumflex artery. So this is our profunda femoris here. And so we have the medial circumflex femoral artery. And so basically elderly people only have an ascending branch of it left. And so if they get a fracture, you can get avascular necrosis because they have no other blood supply coming. So it can be super dangerous for them. But when we think of this, we have two different areas kind of going around. And so there's the cruciate anastomosis, which is around the neck of the femur. So if this is the head of the femur, would be more of the neck, right? And so that ligament of the head of the femur, that's right here. And like I said, that degenerates in people as they get older. And so when you think about the cruciate anastomosis, it's going to be made up of a perforating artery, the branches of inferior gluteal artery, which you can't see on here, and then the transverse branch of the medial and lateral circumflex artery. So the medial will give off a transverse branch, and so will lateral. So both the medial and the lateral give off an ascending, transverse, and descending branch. And so the cruciate's going to be formed by both the transverse ones, plus inferior gluteal artery, plus a perforating artery. Then you're going to have a trochanteric anastomosis around the greater trochanter. So that's going to be like this area right here. And that's going to be both superior and inferior gluteal artery, the medial and lateral circumflex artery. And then it's going to form, these reticular arteries here. And so that's another, because remember, your femur is such a big bone and bones also need blood supply. Like everything needs blood supply. So you want this to be a very well perfused area because, you know, we have a lot of muscles that are in and attaching here. So we care about it a lot. This acetabular artery, this is the one that runs in that ligament of the head of the femur. And so we lose this artery in older patients because remember, we just have that ascending branch of the medial circumflex left. So this gets completely degenerated in older people. And this theoretically should anastomose with the ascending branches of the neck of the femur. So like when you're young, you have that dual blood supply with the acetabular artery. This gets lost in elderly people. So that's the blood supply of the head and the neck of the femur. And then I'll see if I have something of the circumflexes. We'll use this picture. Okay, so let's orient ourselves. So anterior knee and then posterior knee. And so this is our femoral artery slash really would be going into our popliteal artery, but you're gonna have these circumflex femoral arteries and then these genicular arteries. And so they're all gonna anastomose because again, you want something to be well perfused and have blood supply. So you're gonna have a lateral superior genicular, a lateral inferior genicular, a medial inferior genicular, and a medial superior genicular. So those ones I feel like are relatively easy because they're both, you're gonna have superior ones, you're gonna have inferior ones, you're gonna have one that's lateral, and you're gonna have one that's medial. And they're all gonna anastomose and take care of this together. So if you see one coming lateral and superior, that's your lateral superior genicular, medial superior genicular, medial inferior genicular, and then lateral inferior genicular. Then up here, you also have the lateral circumflex femoral, which will help join in. and then this descending genicular. And that descending genicular is what kind of helps give off the medial eventually, and then the lateral. So you have descending genicular, you have two superior genicular, one's lateral, one's medial. You have two inferior genicular, one's lateral, one's medial. And then you have the lateral circumflex femoral artery, which runs laterally. And that's really kind of it for this area. Is going to be the biggest thing. So your popliteal artery right in here, because this is exactly where your pop fossa would split. Because remember, our femoral artery is going to traverse through that adductor. Sural is just for which structures. So sural is so you'll have the artery kind of like here. But really, like when you think of sural, it's more the sural nerve, and that does sensation to your like posterior lateral surface of the foot. But it'll do a little bit of blood supply right in here. But it's nothing like too crazy there that we care about that much. And so posterior. I'll double check for you. Let me look. Okay. Never mind, you're right, because sural will do gastroc, soleus, plantaris, and part of popliteus. Sorry. So do that, and then your posterior tibial will do the rest of your like posterior flexors. So yes. Okay, cool. Sorry, it's been a while since I've looked at some of this. So some of it's a little needs to be a little refreshed, but yes, that's your sural. So think of your like really posterior, so your big plantar flexor. So gastroc, soleus, remember that popliteus runs like right in here too. And then you have that plantaris muscle. So it's like a super small muscle belly and then a really, really long tendon that people get confused with nerves. And that's the plantaris. So sural will do that. Yep. Okay. I think we covered all of blood supply, which is great. And so I think the next thing was some attachments, common insertions and origins for different compartments. Yes. Okay. Um, you say especially when it comes to the foot, I believe. Yeah. Okay. Okay, for all compartments. Um, okay. So let's start with anterior thigh muscle. So remember pectineus, which I didn't really mention earlier, but remember when we think of our femoral triangle, this is going to be that medial floor. And so when it comes to learning insertions and attachments of muscles, I think one of the best ways is using visible body and like visualizing it, because sometimes it's not as important as like, okay, what exactly is it attaching to, but like what's a general consensus of where things are going and coming from. And so remember our pectineus. So this one inserts on our lesser trochanter of the femur. It's going to adduct and slightly flex the hip joint. Our psoas major and iliacus, which makes up our iliopsoas. This inserts on the lesser trochanter of the foot. So it also does, our major hip flexor. Remember iliacus occurs in that iliac crest. So when you think of like the bones of our pelvis, like I kind of think of like almost what looks like a Mickey Mouse ear, and like the inside of it, like that portion is the iliac. Well, the iliac crest is the top, and then the iliac fossa is like the inside. And so the iliac fossa is pretty much where iliacus kind of sits. And that's like a good visualization, especially when you get to see it in lab. And that's always what I think of. Or sartorius, a big one, it originates at the ASIS, so you can really easily palpate that on yourself. So when you feel like a nice little bump around your hip, that's your ASIS, and it inserts at the pes insurine. And so with the pes insurine, we have three muscles that attach there that we really care about. So, well, that only attach there. And the pes serini is sartorius, semitendinosus, and gracilis. So the pes serini is like medial knee is basically what you can think of. It's like the medial of your knee, and it's like very medial in there, and those three muscles attach there. And sartorius is the muscle responsible for like crossing like your legs over one each other. Yeah, I can share part of this. And then when you think of anterior muscles that are acting at the knee joint, so this is when we think about like our quadriceps. And so rectus femoris, that is the AIIS. So that's different from sartorius, which was the ASIS. And rectus femoris is our quadriceps muscle. So it's going to insert on the tendon, quadriceps tendon. Vastus lateralis starts at the greater trochanter. It's a quadriceps muscle, so it's going to insert on the common on the quadriceps tendon. Vastus medialis originates on that intertrochanteric line, inserts on the common quadriceps tendon. Vastus intermedius is going to be anterior and lateral of the femur. Again, insertion quadriceps tendon. So those are all very easy. Then when you think of the adductor muscles, so you have longus, it's going to come from your pubic bone, inserts on the linea aspera. What originates on the linea aspera are short head of the biceps. When we have adductor brevis, it's going to also come from that pubic bone. It inserts on the pectineal line. Adductor magnus comes from the pubic. So you can kind of see like all of these bones are coming from the pubic bone. So your pubis bone, which is like the smaller bone in front when you think of, because your pelvis is kind of made up of three bones. So pubis is one of them. So kind of just like general theme, adductor muscles are coming from the pubis. That's adductor magnus is inserting on the gluteal tuberosity. Gracilis coming from the inferior part of the pubis, so the inferior rami, inserts on that pes serini with semitendinosus and sartorius. Obturator externus is coming from that obturator foramen, and then it's inserting on the trochanteric fossa of the femur. When you think of your abductors and rotators of the thigh, so you have gluteus maximus coming from your ilium, that inserts on your IT tract. And so when we think of our IT tract, we think of also what? Tensor fascia lata, that's going to be in that area. We have gluteus medius coming from the ilium. So when it comes to that, let's see if your long head, well, they both flex the knee joint and laterally rotate, but because the long head is a hamstring, it also has the ability to extend the hip joint. So remember, hamstrings flex the knee, but they can extend the hip. Short head can't do that because it's not a hamstring. So that's that difference. Yeah, perfect. Medius inserts on that greater trochanter. So remember, anytime it's a greater trochanter, all the lateral rotators attach there. So what are the lateral rotators? Like medius, minimus, piriformis, obturator internus, superior and inferior gemelli. So remember, like think about if there's like a place where something inserts and there's multiple things inserting there, chances are they're gonna have like the same functions or do the same. So greater trochanter is going to be our lateral rotators. And so then you have tensor fascia lata originates from the ASIS. Okay, well, what else originates from the ASIS? Sartorius. Yes, it does do a little bit of lateral rotation. And then does mostly extension of the hip joint. Yep. So it does do a little bit, even though it doesn't go exactly on the greater trochanter. It's still going to the iliotibial tract. And if you recall, that's lateral. So it can assist in lateral rotation, but it's not its main function. Tensor fascia lata originates ASIS. Okay, what else originates there? Sartorius. Inserts in the IT tract, and then what inserts there also is gluteus maximus. So kind of thinking of like when it comes to origins insertions, like don't go crazy about it, but if there's more than one that attaches there, then it's probably going to be a little bit more important. Or if something inserts there, what also might originate from there. So it's kind of thinking about those themes when it comes to it. And again, like my advice is like really use visible body for this because like it's more important. Like some of them, yes, you definitely 100% need to know like origin insertion, and those will be the ones you talk about more. But other ones, like don't go crazy. Think about where is it coming from and where is it going approximately. Yes. So I hope that helped with insertions and um uh origins, sorry.